Welcome to the Canadian Cardiovascular Society and Canadian Heart Rhythm Society joint position statement on cardiovascular screening of competitive athletes. This audio recording accompanies the position statement published in the Canadian Journal of Cardiology in 2018. Sudden cardiac death in athletes is a rare occurrence. The exact event rate is somewhat controversial. However, when it occurs, it has a devastating impact on parents, communities, and their teammates. If it takes a village to raise a child, then that entire village becomes bereft with its loss. There is some controversy, however. Some ask, why isn't more screening being done to prevent sudden cardiac death? Whereas others are asking, should we be doing less screening given that the evidence is weak? There are some guidelines available from our American and European colleagues. The American guidelines state that screening should be performed for student athletes or competitive athletes. When performing screening, the 14-point standardized history and physical examination or other society standardized form should be used. These guidelines de-emphasize the ECG and state that it could be considered in association with comprehensive history and physical examination in relatively small cohorts of healthy populations. Of course, this needs to be monitored closely by physician involvement, and quality control needs to be achieved. The European guidelines are slightly different and recommend systematic pre-participation cardiovascular screening of young competitive athletes for detection of abnormalities predisposing to sudden cardiac death. They recommend a standardized history and physical plus a 12-lead ECG. Because of one small region known as Veneto in Italy, ECG as part of screening has greater emphasis in these guidelines. So where does this leave Canada? Our previous work has shown that this meant that in Canada there was great variety and heterogeneity in practice. The CCS sport group set out to develop a standardized approach, bringing us to this position statement. Our group had to consider the following problems. We considered the benefits of testing versus potential problems. We considered that capacity and resources may vary across institutions. We were also very aware that screening could lead to a cascade of follow-up testing, which may also result in unnecessary testing. We also consider the fact whether false positives may lead to unnecessary restriction. And finally, we considered that we were operating in a Canadian healthcare system. We are a socialized system with a strong primary care network, with a system of well checks for most of our population in place. This was our solution to the problem. We developed a stepwise or tiered approach to screening. Here, the components of screening are prioritized according to recommendation intensity. The foundation of the system is the presence of high-quality emergency protocols. This is where institutions should start and is the bedrock of our program. If well-resourced, the next step is to create an enhanced tier. This is where collaboration occurs with other sports physicians, cardiologists, counselors, specialists, and training programs. The tier of excellence is reached following implementation of a shared decision-making approach. More on this later. With respect to individual components, we suggest the history as Tier 1. We then suggest an adjunct physical when there are red flags, and finally the addition of ECG. Again, there will be more on this later. As you can see, we have developed a menu of options, but we have clearly delineated a starting point, and we have emphasized which steps are most important. This allows institutions to tailor a screening program to the resources that they have. We also recognize that there's a need for a network of centers of excellence helping other institutions. In this audio recording, we will not be going through all 10 recommendations in detail, but I will spend time on some of the key ones. Recommendation number 1 is important because it helps us contextualize our program. We recommend an incremental or tiered approach to cardiovascular screening of competitive athletes as part of a broad organization or athlete-centered cardiovascular screening and care of the athletes program, CSCAP. Such screening should occur in the context of a consistent, systematic approach to cardiovascular screening and care that provides full assessment, appropriate investigations, interpretation, management, counseling, and follow-up. This was a strong recommendation from our group, recognizing that there is low quality of evidence in this field overall. The next few recommendations deal with the history, physical exam, and ECG components. Recommendation number 2. We recommend that a history or questionnaire should constitute the initial cardiovascular screening Tier 1, provided it is standardized according to at least one of the AHA, ESE, PPE4, SCBC tools or equivalent. It needs to be accurately interpreted by an appropriately qualified professional experienced in the care of athletes and followed with appropriate investigations as clinically warranted. Clinically warranted findings are those deemed by the interpreter as requiring further assessment, for example by physical examination, investigations such as ECG testing, imaging or stress testing, and/or consultation with a specialist. We felt this was a strong recommendation, recognizing low quality of evidence. Recommendation number 3. We recommend that a physical examination should be considered as an adjunct component of cardiovascular screening of competitive athletes, Tier 2, provided it is performed by an appropriately qualified professional involved in the care of athletes and followed up as clinically warranted. This was a strong recommendation, however, low quality of evidence was recognized. Recommendation number 4. We recommend against the routine performance of a 12-lead ECG for the initial cardiovascular screening of competitive athletes. Routine in this context is defined as first-line or blanket mass performance of ECG not occurring in context of an integrated program as described in number 5. This was a strong recommendation, again with low quality of evidence. Recommendation number 5. We recommend that a 12-lead ECG should be performed for screening of competitive athletes only when indicated by history questionnaire and/or physical examination, targeted screening Tier 3, and provided it is of adequate quality. In this context, adequate is defined as technically sufficient and of the highest possible quality, interpreted by those with appropriate expertise and with consideration of sport history, gender, ethnicity, age, family history, relevant clinical findings, and regional occurrence of disease, and accompanied by appropriate investigations and expert referral if clinically warranted. This was a strong recommendation, again with overall low quality of evidence. Some important notes with respect to the previous 2 recommendations fall under our values and preferences. Our panel clarified that our position for these recommendations does not prohibit organizations from performing ECG screening, but suggests a tiered approach that can be tailored to regional needs, resources, and values. The benefit of mass ECG screening to prevent sudden cardiac death in asymptomatic athletes is very challenging to assess. As further detailed, our current position is that any ECG performance, whether it is targeted or not, must occur in context of an expert-led integrated program. This ensures accuracy, minimization of false positives, prioritization of safety protocols in the case of sudden cardiac arrest, and follow-up of abnormal findings. ECG is not part of blanket screening, nor are we prohibiting it. If institutions decide to do ECG screening, it must be done right. The following recommendations are on shared decision-making, secondary prevention of sudden cardiac death, and cardiovascular emergencies. In this recording, we will only briefly discuss these recommendations as they are fully narrated in our published position statement. We present an approach to shared decision-making which lends itself well to the assessment of athletes, testing of abnormalities, and making a decision with respect to participation. Shared decision-making involves the following 3 steps: choice awareness, an options dialogue, and a decision discussion. Shared decision-making involves ensuring that all involved are fully informed of the degree of uncertainty surrounding a diagnosis and the actual risk of sudden cardiac death, the harms and benefits of the diagnostic cascade and intervention, which could lead to restriction of competition, and finally, alternative approaches to management. Recommendation number 6 emphasizes this shared decision-making approach and can be reviewed in more detail in our publication. In recommendation number 7, we recommend sport restriction be considered and discussed in the following conditions that you can read about in more detail in our position statement. In recommendation number 8, we recommend the creation of specific policies and protocols for the delivery of medical action plans specific to cardiac emergencies in all competitive sports settings and as the foundation of a cardiovascular screening and care of the athletes program. It's important to note that this is a strong recommendation with high quality of evidence. In recommendation number 9, we recommend that all educational and recreational facilities with athletic or sports programs must have AEDs located to ensure rapid access and initiation of defibrillation in less than 3 minutes. They should be placed within close proximity to, if not within, all physical activity spaces used by athletes. Note, this is a strong recommendation with moderate level of evidence. Recommendation 10, our last recommendation, emphasizes the value of AED, CPR, and emergency protocols. Please take a moment to read this recommendation carefully. Note that recommendations 8, 9, and 10 are all strong recommendations because they had either moderate or high quality of evidence associated. In summary, a sequential tiered approach to the identification of cardiac risk has been recommended. Our position statement displays an appreciation of the limits of screening. We also emphasize the importance of shared decision-making. The creation of emergency management policies in sports settings has also been emphasized. These recommendations compose a tiered framework that allows institutions some choice as to program creation. Finally, we emphasize that the creation of a network of centers of excellence with the goals of further implementation, research, and standardization is in Canada's benefit. In the final section of this audio recording, we detail our infographic, which helps explain the shared decision-making process. The first part of the shared decision-making process involves choice awareness. If the athlete consents, then we apply the tiered approach and look for red flags. If there are no red flags, no further testing is required, and the athlete may proceed to participation. If, however, there are some red flags, then this leads us to the options dialogue. During the options dialogue, we do testing. If the testing is normal, then the athlete can proceed to participation. If, however, the testing is abnormal, then a decision discussion needs to be made. Let's go back to our choice awareness step. It could be that the athlete does not consent to screening. Then the question is whether there is an institutional policy in place. If yes, this means that the athlete may not be able to participate and may lead to restriction of participation. If there's no institutional policy, then a discussion needs to happen about what to do next. In the decision discussion, we talk about options, including participation or restriction in a shared decision-making approach. We hope you enjoyed this audio presentation of our position statement. We anticipate further questions and welcome debate. These are Canada's first recommendations for screening of our athletes. We are just warming up. Let's play.